because if they're elderly or if they have vertigo or whatever, they could tip over. So a few seconds, 15 to 20 seconds. Does she have any gait disturbances here? Okay, open your eyes. Good. Put your hands out in front of you, the pronator drift. Okay, good. All right, good. Now I'm going to have her put her hands on her hips, behind her neck, and out straight, up, and then go backwards with them. Okay. Now just put your hands down at your side. I want you to check in muscle strength. Push your arms out against me. That's resistance. Put your hands up here. Give me your fingers. Now you squeeze my fingers. Good. I'm checking for grip equal. Neuro stuff. Now again, I'm gonna push down. You push up. Good. I want you to do up and down. Pronates up and eight. Okay. Now I want you to quickly back and forth. Okay. Good. Alternating stuff. Let's see. Let's have you stand on one foot. Check and balance. Okay. Good. Now put that down and do a squat. Good. Good deal. And have you turn around. And I can look at back. And of course, my number one thing is you're not looking to do anything through clothes. We're going to pretend like she's all just what I need, lots of skin here. So I'm checking scapular alignment. I'm checking the thoracic cage alignment and the iliac crest alignment. Then I have her bend over like you want to touch your toes. And I can walk down the spinal cord. I can make sure that I don't have any scoliosis because my thoracic cages are equal. You can raise up. I have her tilt and tilt. I'm checking range of motion on her spine. Tilt back towards me. Good deal. Okay, can you stand up on your toes? Good. Okay, so I have checked a lot of musculoskeletal stuff by doing that. Have a seat. All right. Then we're going to do ear, nose, and throat. Chocolate chip cookie. And you want to have everything kind of laid out where you're ready to go. This is Welch Allen. Mine, it's because it's old. It's what I started with. Like I said, I've had this for almost 30 years now. And these tips don't fit this one. I like this one because just like that one that he showed you, I can really get a wider view of the tympanic membrane. So I've got my ear tip in. You can either choose a 4 millimeter or the smaller one. There's two sizes. If you're using a little child or somebody with very tiny ear problems, then you want to go with the smaller one because you want to be as comfortable as you can. Turn the light on, and you can look and make sure that it's focused. You can do things like that and focus the light for yourself, particularly with the ophthalmoscope. You want to do that. Then I want to look in her ears, and I pull the ear back. If it was a child, I'd pull up and back to straighten out the canal. I just pull back. Thank you. Seat my speculum in there and take a look. Now don't just go in there, okay, I'm done. Take a look. I'm looking for the cone of light. I'm looking for the umbo and the malleus and all of that. I'm looking at the tympanic membrane itself, and then I'm looking at the canal. I should see that cone of light at the 5 o'clock position here, the 7 o'clock position here. Yes, I have to think it through. Ma'am?
That's 5 left and 7 on the right.
Right. So the other thing you do is you just take a look and make sure those ears are aligned correctly with the eyes. Make sure that you don't have a funny looking kid look, because ears can be offset. If the ears are offset, you want to pay attention to their heart. Eyes can be offset, you pay attention to their kidneys, because one anomaly begets another anomaly, as Terry King will tell you. You check both ears. Look at the external ear, make sure there's no drainage, there's no lesions, there's nothing behind the ear. If you pull on the tragus, does it hurt? A lot of times, swimmer's ear. That is going to be, ooh, ow, you touch that and they're screaming with that. Okay? So you've done both ears. We'll check hearing with the tuning fork. You can do a whisper test first. I can stand over here and say, put your finger here, put your finger there, and I'm gonna whisper something, you tell me what I said. Dog. Okay, good. And then you do the other side. That's a whisper test, it's real easy. The Renee and the Weber, you tune the fork like that, okay? I put it here, I ask her, do you hear it in the right ear or the left or both?
Not at all.
Not at all.
I guess both.
You're supposed to hear it both. All right, and then the other one is, I put it behind her ear on the mastoid process, and you tell me when you stop hearing it. And I'm timing.
Okay.
And then I put it in front of her ear, tell me when it stops.
Oh.
Tell me when it stops. Good. That's a good sign. Bone conduction, air conduction should be greater than bone conduction. You're checking bone conduction here, air conduction here, okay? Tuning fork. Okay. Let's see, do eyes. You can use the same light. You can have a pen light, whatever works for you. Turn this way. All right, so I start with pupils. Just look straight ahead at me, kind of thing, okay? Then I can do I can do cover, uncover, where I cover one eye while I'm looking, and you pull it away and see if there's lag, checking for strabismus. That's a test question. Okay, same thing here, it's a cover, uncover. Good. And then you can cover and check on this side to see if you have contralateral movement, okay? You can check peripheral vision by having her cover your right eye and you cover your left eye. And when you see my fingers come up, you let me know. Okay, now. Okay, so I've done several planes here, and we do the other side, but you have to be close to her when you see my fingers. And you should, she should see them at the same time that you see your fingers, is the deal there. So that's peripheral vision. You can have her extraocular movements. I want you to follow this with your eyes, don't move your head. So you go lateral. Don't go too fast on this, guys. Lateral, up, down. You're looking for nystagmus. Good. And then you can bring towards the middle. Good. Very good. Okay. All right. So then you can do your ophthalmoscope exam. When you get your ophthalmoscope, have something that you can look at to focus it to your eye, okay, before you do it, because like this is not focused to my eye. There we go, that's perfect. Then you want to look, you're looking in that eye for the optic disc, the vessels, and you're trying to see the macula. If you go in at kind of an angle towards the nose, okay, and you're looking this way, you're going to catch your disc. And if you keep your line steady here horizontally, and then just move laterally towards the ear, you're going to be able to pick up the macula. You're not going to find the macula at first. It's going to take you a while to get there, but keep practicing. I want you to find the disc. I want you to be able to identify the veins and arteries and looking to see if there's any nicking. I want you to see if there's anything like artifacts, bleeding spots, hemorrhagic areas, cotton wool spots, looks like pieces of cotton down in the back of the fundus of the eye, or anything like that. So you go in, and I usually will kind of place my hand on their head and lift their eyelid up a little bit just to get that out of my way. Now, they have to be at your eye level. Okay. And then I start in, and I've got my red reflex, and I'm working my way in till I get there, and it's horrible for her, but I see the disc, and then I see vessels, and oh, there's the macula. You'll know you saw the macula because she's gonna water up. You don't spend a whole lot of time in there, but people are gonna hate you for doing this. All right, but you do both eyes like that. Always look at conjunctiva. Okay, and making sure you don't have any foreign bodies or anything up in there. Good, and checking the puncta in the center here for any drainage or any swelling or anything like that. Especially the little ones, they'll get occlusions there of mucus and stuff. Have her raise her eyebrows. Good. All right, puff out your cheeks. Show me your teeth. Good. I want you to turn your head hard to the left, okay, and hard to the left, okay. Whatever kind of way that is. Now tilt your head all the way back and all the way down. Checking range of motion on the neck, okay. I can look in her nose. I want to check the turbinates there. You check for smell and patency. You can have her. Can you breathe? Can you breathe? Yeah. And you can have things like a piece of alcohol swab or something, close your eyes, what does it smell like? You can have cinnamon or coffee or whatever, but you check for, especially if you think you have some cranial nerve injuries, checking for smell. And then you look, now a lot of times I'll have the speculum on there, so I can get up inside the nares, and most people don't do this, but you guys need to do it, because you can look at the turbinates and just go right up in there, get a really good look at them. Okay? And you're looking to see if there's any polyps in there, if there's any swelling of the turbinates, if there's patency, if there's exudates up in there, just anything that's abnormal. Yeah, we gotta do the mouth. I'm just trying to think if I missed anything on the nose. I think we're good there. Yeah, you're looking for the septum, making sure that it's not deviated. Had a little guy come in the other day that was lifting weights in football practice, and he hit the bridge of his nose and fractured that thing. So definitely was some swelling up in there. Okay, when you get to the mouth, again, it's not like, I'm done. Don't look around. You want to look at the ducts, the Wharton's duct and Stevens duct. Make sure that there's moisture. You're looking to see if there's any petechiae, what the gums look like. So look around the mouth. Look at the palate. Make sure it's intact. Look at the, then have her say, ah. You're looking for the uvula. Does it go up when she says that? Okay, then stick your tongue out and say, ah. And you really get a nice look back there at the tonsils. You can grade them, like grade 0, 1, 2, 3, 4, with the biggest number meaning they're touching the uvula. Looking for exudates, discharge, postnasal discharge. A lot of times in our communities, we see people with a lot of allergies, and they'll have what you call a cobblestone look in their throat, and it looks like a cobblestone street in the back of their throat from all the allergies and stuff that's chronic that they've been dealing with, and lots of drainage. Looking for redness. Odor. Strep throat has a very distinctive odor. You got kids, you probably have been around a strep throat once or two. Let's see. You check the ducts to make sure that there's drainage, there's moisture. Looking at the teeth, all of that. Sometimes you can see, like in strep throat or other situations, you can see petechiae up on the upper palate. That's important to pay attention to. You can see, remember this, you may see the tonsils, but you don't always see the lower tonsils behind that. There can be some, if you've got a stinky odor coming out, it's not a positive strep, you may have a tonsil problem, like it could be an abscess back in there, something like that. So explore, look, listen to their history. What do they tell you? When did it start? What are the other symptoms that go with it? All of that history in with what you look at and do is very relevant to what's going on, okay? Then you want to check TMJ. Just put your finger right in front of the ear and open, and you feel it for the click. Okay, hope you're taking care of that. All right. Okay, checking the thyroid. I always check the thyroid from the back, but first you want to look and have them swallow. If you see any abnormal movement, you can check the trachea, see if it's midline, and then from the back, tilt your head over, so, and then have them swallow, and you can feel that thyroid, and you go the other way. And as they swallow, you feel the thyroid slide up and down. Ashley, if I missed anything, we're doing good, okay. Lymph nodes, you want to check those. You want to check preauricular, which is right in front of the ear. A lot of times that can be particularly with external otitis, possibly with anything up above like eye infections, things like that. You could possibly have some tenderness there. You want to check posterior auricular, behind the ear. You check the posterior cervicals, the anterior cervicals, the submandibular, and then your deep clavicular. You don't want to find something there. And sometimes if they do shrug, you can actually feel it better there. And then when you get down to other parts, you check axillary nodes and inguinal nodes and stuff when you're doing other parts of the body. So pretty good on HENT. Might have missed one or two things, I'm not real sure, but the big things that I expect you to do, I've covered. Respiratory, of course, you're looking to see are they breathing smoothly. By doing your nose, you're looking at AP diameter. This should be 1:2 ratio, okay? Otherwise, you're probably looking at some, like a barrel chest COPD kind of patient, something like that. Looking to see, is there symmetrical movement? One of the things that you can do to check that is the thoracic expansion. If you put your hands here and have them take a deep breath, you watch how and then you watch how your thumbs move. And do they move symmetrically as she does that? Listen with your stethoscope but when you listen to respiratory, and this is a test question too, you're comparing right to left. So you don't go all the way down on the right, all the way down on the left. You go right, left, right, left, right, left, right, left, and then don't forget axillary line. What do you think you're listening to in the right axillary line? What part of the lung? Anybody guess? Think of your anatomy and physiology. Put you on the spot. Right? Middle lobe. Who said that? Yay! Points for you. Exactly. And that is about the best place to hear the right middle lobe is in the right axillary line. Okay? Same thing here. You go right, left, right, left, right, left, right, left, over here, and over here. Listening all the time. And if it's an older patient, you want to be careful that you're not just making them breathe deep, give them a little time to rest in between. You can check for fremitus. If you're skin to skin, you can say 99. 99. And you're checking to see that the fremitus is equal. Okay? Increased fremitus could be consolidation of some type of respiratory problem. When you're listening for rales, bronchi, wheezing, all those adventitious sounds. You can percuss. Percussing is, you can tell I've percussed a lot. I have horrible joints now. But if you will percuss with one finger down, if you put all your fingers on their skin, you're going to dampen the sound. One finger down, percuss. I like this. It's much louder. I can hear it. So I would percuss like. and you percuss all the way down, just like you listen. Again, checking for tympany versus other types of sounds, okay? Dullness and such as that. Dullness is not good. It should be tympanic over most of the lung areas. We can do what's called diaphragmatic excursion. The purpose of this, and you won't do it very often, but you do need to know how, to see how much movement the diaphragm has between inspiration and expiration. And let me just kind of sit there for a second so y'all can see over me. This is a bare back. And sometimes it's better, no, it's okay. Just kind of keep your arms in front of you. You can think where that diaphragm lives, okay? It's probably around here somewhere. So I'm percussing down until I find a change in the sound, which tells me I've reached the diaphragm. So what you do is you have her take it, first of all, think it through, because this is where I find the students getting in trouble. If she takes a deep breath, will her diaphragm be higher or lower?
Higher.
Hello?
Lower.
If she takes a deep breath and holds it in, it should be lower, okay? So if I have her take a deep breath, I'm gonna go down until the sound changes and say, go ahead and breathe. And then I'm gonna have her take a deep breath and blow it out. I would expect it to be higher. So I've already marked a spot here. I'll percuss here while she's not breathing for a second and see the difference between the two, okay? So I would say, I want you to take a deep breath and hold it. And it changed right there, breathe. So I would have made a mark right here. And then I want you to take a deep breath and blow it out and then not breathe for a second. And you can't hear, go ahead and breathe through closed, but that's, with the skin, you would be able to hear the difference. You measure here and see what the difference is, then you do it over here and measure to see the difference. You're looking at, I think it's 4 to 6 millimeters or something right in here that you want, that's reasonable and that you would expect that much movement of the diaphragm. But the reason that you do that is to check the quality of the diaphragm muscle, okay? And also symmetry. That's respiratory. You can check fremitus on the front as well. Again, it's 99, 99, 99 to compare. Okay, then heart is apple pie, thanks Mom a lot, aortic, pulmonic. So you check with the diaphragm, and then you go all the way around and check all the way down to the mitral area. Then you turn it to the bell, and you go back. I do it, I go, listen, 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 listen. And then I flip over to the bell, and I come up, listen, listen. Because with the bell, I can hear murmurs a lot better, okay? I can also use the bell over the carotid. Take a deep breath and hold it. Listen for any bruits. Breathe normally. Now, take a deep breath and hold it. And again, listen for bruits. This is what I was talking about a while ago with the bell. A bell is really an important part of your stethoscope versus having 2 diaphragms, which is what this has. I can take that off maybe and make a bell, but this bell is going to be your best friend in listening for any type of murmurs. And when you put the bell down, you don't put it down with pressure, because all you've done is created another diaphragm. A bell is just very lightly applied. It's the best way to catch any kind of abnormal sounds with the bell. So, you want to check for the PMI, the point of maximal impulse. You do that by putting your hand right up underneath where you think it is, and you're feeling for the pulse. If it should be at the 5th intercostal space mid-clavicular line. If it's not there, it's shifted laterally. What do you think caused that? Think about it. What? Don't be afraid. Say that loud. I'm old. Somebody. Yeah. Usually it's like ventricle enlargement or something like that. So it's important to know where the PMI is. And you're also feeling here and up above on the chest. Are there any thrills lifts, heaves, that type of thing. You can look at the neck and just visualize if you have jugular venous distension. If you do, then you do want to go into all the trouble of measuring and that type of thing, but most of the time just doing a good quick visual, you can see that you don't have any distension there. Okay, so then you lay your patient down, so put your legs at the other end and lay on your back.
This way?
No, and put your legs here.
Okay.
Lay down. And you would do the heart again. And you would also do, always pull that out too, because I don't want the feet hanging. And you would do your breast exam, which I have the model out there somewhere, but when you do a breast exam, if you've not done one before, you always start the same way every time, whatever way you do. I do circles. I start at the nipple, and I work my way around in concentric circles until I get there, and I make sure, with our arm up like so, that I'm checking the axillary nodes really well. And I also use that at the time to teach her. I'll be sure she knows how to do it, and I have her show me how to do it. Do the other side, same way. If you see anything unusual in the chest wall, like retractions or any asymmetric kind of stuff, you just pay attention to that kind of stuff. Then it's time to do the belly. You always want to just look first, because if you start poking around, you're going to change the vowel sounds. So you want to listen, look, listen, feel. That's the best way to think of that with the belly. And I'm going to tell you, most of the time when people come to the checkoff time, that's where they have the most trouble, is the belly. So I wanted to take this time to show you what I consider to be a good belly assessment. Okay, what's your shape? That's a cute belly. Hey. Put you on the spot, I'm so sorry. So I'm looking to see if I'm looking over the aorta area, is it pulsing? I'm looking to see if there's any waves or anything like that. Then I want to listen. And I'll listen in all 4 quadrants with the diaphragm. Okay, and with the bell, I can go back and listen over the arteries, the renal and the iliac arteries, and over the aorta, listening for bruits. Okay. Then you can begin to palpate. So then you can just start with light palpation, just all around, anything tender. And sometimes just watch their face, because if they'll let you know. They might not say anything, but their face will let you know. And then you go with a deeper palpation, 2 hands, feeling for any masses or anything that doesn't feel right. You go all the way down into here, checking your thermal pulses while you're in there. Aorta, grab a hold of that sucker, like so. One finger on either side. And I can tell if there's any ballooning or aneurysm kind of thing. Especially high-risk men over 50 who have ever smoked should have their aortas checked. And if you feel anything, you send them for studies, CAT scans and such as that, because they're high risk for AAAs. Okay? You've got to feel you can feel for lymph nodes here in this area. You want to feel for your spleen and your liver. And this is where and your kidneys. A couple of things I'm going to show you. People have trouble with this. But the spleen, which side is it on? Good, on the left. You feel here. I got a 16-year-old who comes in with a sore throat and I'm feeling tired and run down. Always check their spleen. They could have a mono. And if you feel a hot spleen, get your hands off of it, because you don't want to mess with it. If they're hot enough that you're feeling them down here, well below the rib cage, they need to be evaluated diagnostically, because that spleen is very easy to rupture. Liver, a little difficult. In some people, I think will be fine here, but it's there's 2 ways that you can check the liver, just feeling it. You can come here and kind of hook the cage and just have her take a deep breath and blow it out. Yeah. And you'll feel it just kind of flip over your fingertips. That's good. If I felt it down here, then you've got some issues. The other way to do it, that was gracious. Here, 2 hands, again, take a deep breath. And I'm pushing up underneath that rib cage, blow it out. And I feel it again. Just that rush of the liver on my fingertips. Liver span. Oh, you can percuss the whole belly, and it's a good thing to do. Ooh, it's hungry. All right, good. Liver span. That was a good salmon belly though. You want to start, it's mid-clavicular line is what we're measuring, okay? You start right up under the nipple area and you percuss till it changes sounds. Y'all heard it? You would mark it right there. And then you start at the belly button. And that's it. Then you mark those 2 spots, and that's my span. I think 6 to 12 centimeters is normal span for a liver, right on the mid-clavicular line. You want to know if the liver's too big. That's why you do that. You check your femoral pulses. While she's laying there, I can do some range of motion. Like if I thought she had appendicitis, typically it's right lower quadrant, rebound tenderness. If I push down and I come up and she says, "Oh my God, you're killing me," that's rebound tenderness. I can do some tests like so. She couldn't stand that if there was appendix issues there. I can rotate the hips. Okay, I'm checking the knees. That will click there. Yeah. Okay. Do the same thing over here. Okay, we're gonna rotate your hip out. Good. And then you can have her do things like push your legs out against me. Okay, and push them in. Good. You can check. I get a lot of knee complaints. One of the things you can check is varus valgus maneuvers. You can do. Let me just have your leg. I'm going to push. Got one hand here, one hand here. I'm pushing in. And does that hurt? And you do it opposite, like so. You're checking ligaments. It's a good test. Varus valgus strain. Do it on either side. You can do a drawer maneuver where you literally have to almost sit on her foot, and then if I were sitting there, then I'm going to pull out to see if it's stable, and it is. You can do the same thing with the ankle. You support it, and then you pull it out to see if the joint is loose. Let's see. Okay, sit up. You're such a good patient. Reflexes and sensation. I like this hammer for checking sensation. Think about this. If I've got good sensation at my most distal area, I can expect that it's here too, up in the normal proximal. So you can start with the hand, have your patient close their eyes, and you can say, I'm going to strike this thing, it's going to vibrate, and I'm going to put it here, and you tell me when it stops vibrating. So here we go. You tell me, you feel the vibration? Okay, just let me know when it stops. Okay, and I stopped it, but if she had her eyes open, she could tell me, and I wouldn't know if she got it right. So you just pick a bony prominence. You feel it? Okay, and we'll just out. Good. You can the neuro hammer. It comes with a nifty little sharp point and a nifty little soft point. And you can say, close your eyes, is this soft or sharp?
Sharp.
Tell me now what this is.
Sharp.
And this?
Soft. Soft. Soft.
Or you can use a cotton ball to do that, but it's a good way just to, and I wouldn't stick a lip pin on the face, but you can use a cotton tip applicator to do that, and break it in half and use the cotton tip part and the wood part, do soft and sharp. You can do 3-point or 2-point discrimination, where you would have like a safety pin or something, and tell me if you're 2 points or 1. So then you're checking your neurovascular stuff like that. Reflexes. What are we doing? Oh Lord. Oh Lord. Okay, you can check. Ooh, that was good. You did good. Have her just drop your arm in my hand. Totally relax. Check right here. You don't always hit them. You kind of have to feel where you're supposed to hit. It's right there. That's good. So you check those. You can check right in here. Yeah. And then you can check patellar. Y'all, I do patellar like this nowadays, but you can use your hammer. See, she got good reflexes there. You can do reflexes on your belly out from the umbilicus. You can just slightly stroke, and you should see a little muscle jerk. You can do the Achilles with their shoe on. Put their foot in your hand and strike. I use the flat part and strike against the back of their heel, and you'll feel their foot move. Okay? Babinski, we don't necessarily do. That would be somebody who's up in the bed with a neuro head injury, and then you would do the Babinski, but like so across the bottom of the foot and look for the arching of the toes. Of course, you would take their shoes off, check for any redness, any deformities or whatever. When you're looking at them, you're looking at the hands, you're looking at all the joints, getting movement of all the joints as you work your way through, any swelling or tenderness. You can check capillary refill, all the things that have to do with good circulation, that type of thing. And that's it. And we don't expect you to do the GYN and the PAPS of the pelvic for your checkoff. If you have an opportunity in clinical, yes, do that. I did set the female model out just to show you something. When you do your exam, the first thing you want to do is, I hate these, they're horrible, but actually closed, like so. Do an external exam, checking the schemes and Bartholin glands, looking for any lesions, HPV, just everywhere. I usually use a little bit of lubricant on my speculum. Ours has a light in it, but you need to have a really good light if it doesn't, like this. I will put my finger here at the introitus and kind of relax that muscle a little bit. I'll tell my patient, breathe in nice and deep and breathe out and just relax. And then your speculum goes in oblique, like so. You don't go in like this. Okay, please never. So you go in oblique, and then you turn it, open the speculum up to let the cervix pop in right here. Trick, if you have a really heavy, obese person, you can take a glove and cut the finger and the tip off of the finger, so you have like a sheath, put it on here, and it'll keep the excess tissue from falling in front of the cervix. So it's just a little trick. But when you're in there, then you do the you'll swab. There's a little purple brush-looking thing. You put that into the os of the cervix for about 15 to 20 seconds. Just kind of circle it around, take it out, and put it in the solution. The nurse takes care of it from there and sends it off. Then you do a bimanual exam, which 2 fingers in, hand up here, filling the cervix and the uterus and the tubes, and you're feeling for the cervix, which there it is. You touch that cervix. Does it hurt? Does she scream when you do that? That's cervical motion tenderness. Checking the ovaries is adnexal tenderness. Checking the size of the uterus, which feels normal in this case. But you can also do the anal. Some people do both. I was taught to do it this way. But I do check to make sure that the anus has got a good sphincter muscle kind of thing. Older women, you can, as you're doing the bimanual, tell them to squeeze your fingers, and that will give you an idea if there's muscle tone down there. Looking in there, you look for dryness, you look for, older women are gonna have really thin looking rugae. I mean, it's almost like to the point that it'll bleed easily, so thin. Younger women should have an almost cobblestone looking rugae. It should look that beefy and healthy. Looking for discharge, looking cervix to see if there's lesions on the cervix or if there's strawberry spots on the cervix. I had one the other day that was, I wish I'd had a student. It was the most perfect strawberry cervix I've ever seen. And yes, she had trichomonas. So a lot of things you can see when you do a pelvic exam. So if somebody gives you the opportunity in clinical to do one, grab it. Go with them and be willing to jump in and do it. Jump in and learn. Don't turn anything down. If you have a man and you need to do a prostate exam, I don't do them because my fingers are too short. I let the docs do it, but to do it, I've got a model set here. Y'all are willing to, y'all are glad to take a look. With them bent over the table, the thing is, if you go in like so, that anus is gonna contract and it's not gonna let you in. If you will put your finger here with the glove finger and kind of just push a little bit gently, it'll begin to relax that muscle so that you can then put your finger up in there and you're feeling, and I can feel this one, you're feeling for the prostate gland. It should be, it's about that far in, and you're feeling, does it feel bigger on one side than the other? Is it tender? Is it boggy? Or does it feel firm? Do you feel nodules on it? And of course we do PSAs a lot now, prostate surface antigen test, but they need to have a digital rectal exam too, at least every few years to make sure. But like I said, the guys in our clinic don't do the girls, and we don't do hardly any of the guys. If you have to have a guy that you think has an STD, then you check the penis, checking for discharge there. You can literally just swab it up inside the urethra and get your gen probe for that, and or you can do a urine test, but personally I do the swabs. You can also, and then we do, of course, the blood testing. Let's see. I think that's, I have a breast model, but it's, I mean, y'all have all been exposed to breast exams. I think that's kind of everything. For your checkoff, you don't have to do prostate and female. You just have to do all of those basic things, okay? You have some videos coming up, those in 5007. I cut them down. There used to be 5 videos. Last time I cut them down to 3. So like I put the HENT and neuro together because they do go together. A lot of the things you check with ear, nose, and throat are also things you check for neuro exam. So you'll put those 2 pieces together and do a video. And the video is just us giving you feedback. It's not like, oh my God, you're failing the class. It's like I can say, Lindsay, when you do that otoscope, how you hold it makes a difference, and you look like you were gonna hit the patient with it or something. You know, look for, I will give you tips, things to help you, and it'll be your clinical people that are looking at your video. We did heart and lungs together this time, and I think I did GU as the 3rd one for y'all. So you only have 3 videos to do. You can do like on your telephone, have somebody just video you doing it, and you can do it on your husband, your wife, your kids, I don't care. I just want to see you doing the skills. And then when you come here to do your checkoff, you will, you and your partner will have 3 different people going at one time, and a faculty member will be with each table, and you'll go through it and just start with the standing up and work your way to laying down and go through the whole thing.